you have to keep the patient in anatomical position. Okay, so what is anatomical position? Okay, so you just keep the patient in anatomical position. The first step you have to do. Okay, so I'm not going to discuss all the introduction, permission, that you already know about that, right? So approach to the patient, right? So after you introduce yourself, ask for the permission, keep the patient's in anatomical position, and then in orthopedics, next step what you have to do is exposure. Okay, so for exposure, what you have to do is in upper limb, you have to expose from sternoclavicular joint. Okay, so if lower limb, you have to expose from the iliac crest, except from the private part, you have to expose from. So in upper limb, so meaning the upper chest. So up to the upper chest, you have to expose. Okay, so keep the patient in anatomical position and expose. So in this stage, if the patient cannot stay in anatomical position, right? So cannot stay in the anatomical position, you will have the idea, you will have to clue. So where is the problem? Maybe problem is something in the shoulder, something in the problem is elbow, like this. Okay, so don't think about the diagnosis, think about the problem. What is the problem? What is the issue with this patient? Okay, so most of the common mistake in the medical student is that if I ask you, examine shoulder, you start to pull the patient. Okay, so you will miss the other information from the inspection. In orthopedics we call look. Okay, so in internal medicine you call palpation, we call feel. Okay, and then in orthopedics is the locomotor system, so we call move. Okay, so these three steps: look, feel, move, and sometimes in lower limb measure. Okay, so first what you have to do, so patient whether can stay in the anatomical position or not. Patient cannot stay in anatomical position, meaning that something wrong with them, patient or not. Okay, so next step, what you have to just get is that whatever you see, you have to describe here. If you see swelling, describe swelling like in the general surgery. Right? If you see ulcer, you have to describe as in the general surgery. If you see surgical scar, you have to describe as a describe the surgical scar. But in general orthopedics, what is significant is wasting. Okay, so the muscle wasting because this is the locomotor. So normally in upper limb, what you see here, shoulder, deltoid. Okay, so you have to see the whether deltoid muscle is wasted. Okay, so you have to see.
Vẫn là angle move.
Phone or something.
Oh, no, because then I go.
So next step, so what you need to do is so if you ask the patients to push the wall, you can see that if there is any asymmetry in the shoulder, scapula, you can comment on this. So you already know in the general surgery what we got this condition. Winning on the scapula, right? So this one is only in locking stage. Okay, you just look what do you see, what do you see. So now wasting, deformity, abnormality. Okay, so if you see deformity, you have to describe the deformity of scapula, not only scapula, but in any deformity. So this is what we call varus deformity. Okay, this is varus deformity. Okay, so lower limb also varus. Okay, so this is deformity. Push the exacerbations to push the wall. You will see the asymmetry deformity in the scapula, and you can see the deltoid wasting. Yeah, shoulder, supraspinatus, and trapezius wasting. Even if you do not remember the name of the muscle, doesn't matter. There is no wasting in the back, neck, shoulder, and comment like this. Okay, so this is in looking station. So depends on the case, you need to add something like with tumor, swelling, you see the side shape, and overlying skin structure. So that after that, you have to look, feel. Okay. So only then, after you description around 2 minutes. Okay. Question is 6 minutes. Around 2 minutes, you describe about your finding in the looking stage. You start to feel the patient. So before this, what you can ask is there any pain in the patient? So in OSCE, in shock case, you are not supposed to communicate with the patient, right? So don't ask the history. You cannot ask the history. What happened to you? How are you, right? So you can check the identity, then after that finish. So what happened to you? How long it is? You cannot ask the question. So this is the physical examination skill, right? So after that, only you can ask the one question: is there any pain? Okay. So patient say pain is here. Okay, you have to be sure I'm not going to make you more painful in this area, something like that. Yeah. If the patient say pain is here, you will have the idea. Okay, I have to examine this. If the patient say pain is here, you have the idea. So because that now in EOP, I will ask you occasional examination, I will ask you the examination like this. Okay. So but in EO14, PD2, we are not going to ask you like this. We give you the scenario. Based on this scenario, you have to decide where you have to examine. Right? So in EOP, it's just okay, just practice for you. So examine, shoulder examination, examination. So in final exam, it's not like that. You read the scenario and decide, I have to examine shoulder or KB, right? So in this case, this systematic approach is important. Because if you do not approach systematically, you will miss the important finding in some steps. Then you will not get the diagnosis, right? So because of this, you need to ask the patients where is the pain. Okay. So patient say pain is here. Okay. The idea. Okay. You examine the side. Pain is here. Pain is here. Then you will have the idea which you have to use. Okay. Then you feel the temperature, right? Okay. You want to feel here or here, that's okay. So if you have your own explanation, you can use the side of that time. Okay. Temperature, after that, tenderness. Okay. So in orthopedics, so to exclude the fracture, you use your thumb, starting from clavicle, keep the white pressure over the bony bronchus. Okay. So there is no pain in clavicle. Okay. There is no pain around the glenoid. There is no pain over the scapula. Okay. There is no pain along the arm, no pain on medial condyle, lateral condyle, no pain radius, wrist, go down like this. Okay. So you better to give the running commentary what you are doing. So otherwise, the examiner also don't know what you are doing. You also do not know what is your finding, and then you just feel. Okay. So to elicit the tenderness, like this. Okay. This is massage. To elicit the bony tenderness, also please use your thumb. Keep the white pressure over the bony bronchus. Then you can see being present. Okay, so temperature, tenderness, and disturbance. Okay, so feel the disturbance. So lower limb also same. Temperature, tenderness, disturbance. So in lock-in stage, so I will summarize again. First, you have to do position. Second, exposure. Okay, second exposure. After position and exposure, you look from front, you look from side, and you look from. Okay, so don't just look in stage. Don't just look around like this, and there is no scar, no dilated vein, no swelling, no. Don't do like this. Okay, you have to show the examiner you are really checking the patient. Okay, so because of this, don't just look at there is no scar, no dilated vein. Don't say like this. Okay. So you just look, okay, I'm looking from front, there is no muscle wasting, no, okay, then I look from the side, there is no deltoid wasting, okay, so there is no symmetry, asymmetry are there, scapula. Sometimes some students used to do like this, they just try to memorize the step, what I have to say, and then you just look at the front, and there is no scapula, no any other scapula, okay. So don't do that. You show the examiner you are really checking the patient. Okay, so after looking, you have to do 3 things: feel temperature, tenderness, and disturbance. Okay, temperature, so you already know. Tenderness, use in orthopedics, use that. So your thumb starting from bone point, vertical, scapula, glenoid, iliac-condyle, lateral-condyle, down to the wrist. So in this case, in tenderness, sometimes patient say pain here. Okay, sometimes patient will say pain here. If patient say pain here, don't start here. Okay, don't start here because if you start the painful area, patient will be very painful, and then you cannot continue your examination. Okay, so don't start it. The patient say pain here, you start to turn away from the painful area. Then you can comment pain is around the isolating around the elbow. Okay, patient say pain here, you start from the distance, you start from here, pain is around the shoulder. Have to do that. Don't start with the painful area. So in practical, if you start, you cannot continue with the other. Patient will not compromise. So this is the okay. So look, feel, move. Okay. So in movement, okay. So the best is ask the patients to follow your movement, because sometimes some patient may be intelligent, some patient even do not know what is the flexion extension. Okay. So for upper limb, shoulder, and keep the adequate distance with the patient. Okay, so I don't know why some student as a patient to abduct under your faces. Okay, so keep the adequate distance with the patient, and then as the patients to follow. This is the forward flexion, right? This is forward flexion. This is backward extension. Okay, so this is ABD, right? This is ABD. This is elevation. So from here to here is elevation. Okay, so this is ABD. Okay, from here to here is from ABD. This is normal. Okay, so this is not attached in AD. Okay, this is AD, attached. Okay, this is attached. This is external rotation. This is internal rotation. Don't touch like this. Okay, external rotation, internal rotation. Don't touch like this. You know why? This is your forearm supination rotation, not shoulder. Okay, shoulder. External rotation, internal rotation, you have to check like this. Okay, external rotation, internal rotation. Okay, so this is the active as the patients to follow your movement. Only after that, what you have to do is you have to do the assist movement. Yeah? So why we have to do active movement first, followed by assist movement is that if there is pain, if there is limitation during the active movement, you will notice where is the problem. So in this case, then you need to confirm this limitation of movement is here present. Otherwise, if you don't know and then just pull and move the patient has the shoulder dislocation, fracture, what will you do? Right? So because of this, make sure patient can move all direction of movement actively. But only after that you go, patient abduction is normal, patient forward flexion is normal, patient backward extension is normal, patient external rotation is normal, patient is internal rotation is normal. Okay, so the principle in the physical examination is orthopedics in both upper limb and lower limb. Active first versus later. Okay, so if the patient say one side is painful, start with the normal side first, then on the side later. When go side or this later. Okay, so this is the principle of the movement. Okay, so here I need to explain a little bit about this abduction. Okay, so this is your APD. This abduction is a movement of the two muscle. This is a supraspinatus, and this is the delta. So from 0 to around 130 degrees is supraspinatus. So after 30 degree to 90 degree is spine deltoid muscle. Okay, so this is by rotation of your scapula. Okay, not by the glenohumeral movement. Okay, so if you put your hand here and then as a patient, after this you will see the rotation. You will feel the rotation of if you put your hand here. So because of this, sometimes we call this elevation, not abduction. Okay. So the problem is that if you do not have the supraspinatus muscle, for example, rupture of the supraspinatus muscle, you cannot do this. Okay, you cannot do this. So, but you can still do from here to here. Okay, you can still do from here to here because your deltoid is say intact. So because of this, patient with the supraspinatus muscle, right, rupture, if you ask the patients to do this, how they do, they bend the body and what they do, because with the action of the deltoid muscle. Because from here to here is my action of the, from here to here is supraspinatus. Supraspinatus cannot initiate, then bend the body like this. Okay. So this is the signs of the supraspinatus tendon rupture. Okay. So inflammation like I will explain. Okay. So this is the look, feel, move. Okay. In movement, the principle is active movement first, followed by rest. Okay. So you have to understand how many movement you have to. Actually, this is very simple. So how many movement you can see, you can imagine your shoulder, how much movement I can do as the patient to follow. Okay. Okay, so far any questions? Okay. So if you do not have any question, I give you assignment. This front row, okay. Read the rotator cuff muscle and their action. Okay. That's second row, read about the supraspinatus impingement syndrome.